Listeners, I've got to tell you one thing. He has a course. I was listening to part of it, and that's where I'm going to lead it to. Allegra.
Yes.
Can you talk to us a little bit about this research and how you did the education in regards to that?
Allegra is a very interesting story, and I tell you why. The story is the following. I was at what is now Novartis, it was SIBA at the time, as head of research for the US, and should have become the global head of research and development for SIBA, which shortly thereafter became Novartis. But because I was Black, they actually called me to Switzerland and told me because I was Black, and I would have been, one, the first American, and secondly, of course, the first Black to be on their board in Switzerland, that was not going to work. So I was not going to get that position.
Wow.
So I looked around for an American company and ended up at Marion Meridau, which was a mid-sized company, as global head of research and development.
You're listening to Cold Press Conversations with Dr. Jewel White Williams, a lover of numbers, lists, and a good glass of cold press juice, who is sharing episodes each week to help you explore the back end of healthcare and health sciences, where a lot of that grit is done. We'll dive into topics covering research, education, and clinical practices, as well as guest shows with other leaders in the field. Pull up a seat and let's dive into these amazing and game-changing conversations. Hello, everyone, and welcome to Cold Press Conversations. And we're going to be focusing on health literacy. I am your host, Dr. Jewel, and today we have a special guest, Dr. Frank L. Douglas. He is an award-winning and former pharmaceutical executive who has been recognized both for his innovative approaches as well as his commitment to equity and inclusion. He overcame episodes of discrimination in academia and industry and became the first Black to be on the board of management of a top 5 global pharmaceutical company. Many of his awards is being named the 2007 Black History Maker. He received his BS from Lehigh University and a PhD and MD from Cornell University. I welcome you, Dr. Douglas.
Thank you very much. I'm happy to be here.
Oh, this is awesome. I mean, I just want to let people know that we're going to be diving into so much today. We're going to just go ahead and learn a little bit about his background. But the midst of what we're going to be focusing on is his specialty, which he has a book right now, Until You Walk in My Shoes. And it's about a reframing process. But we're going to take it from a healthcare perspective, dealing with how we can look at it from health literacy. How can we become more aware, more literate about health and healthcare? And, Dr. Douglas, before we go further, I had a chance to read a lot of your work. I have to say, it was a lot of information that you provided us. Just give us a little insight about the journey which led you to where you are today, how you encountered this concept and what made you evolve to where you are.
If I may, let me share an anecdote which will tell you why this is so important to me. I came to America in 1963, actually 8 days before Dr. Martin Luther King's famous march on Washington. And within those 8 days, I discovered what it was to be judged by the color of my skin and not by the content of my character. I learned later that in that march, he actually made that statement that one day he wished that his children would be judged by the content of their character, not by the color of their skin. Fast forward, I completed my PhD. I'm hired by Xerox as an assistant scientist. And for 3 months, I could not get a good project. And one day, a young white man joined the group. And within a week, he was placed on what was the hottest project we had in research and development in Xerox at the time. I went to see my manager to have yet another discussion. And I was stunned when I said to him, Steve, don't think of me as though I'm Frank. Think of me as though I am Bob. And it was so amazing to watch the recognition come on his face as he said to me, Bob has been here a week and I've put him on the artery project. Well, I was furious. I made it out of his office, down to the office of the senior vice president, to give him another example of my being discriminated against. Well, that led me, as a matter of fact, to go to medical school. But about 2 years thereafter, I thought of that episode and realized that I had made 2 errors. The first error was the following. The senior vice president, Dr. Tribus, that summer had hired 3 young Black PhDs to join the one Black PhD that Xerox had in R&D and research and development at the time. So it probably was more important to him that Frank Douglas would do well than it was to Frank Douglas. The second one was, what was my desired outcome? I wanted to get a good project. It was not for the senior vice president to go and have tough words with my manager. So had I reframed and had I said to Dr. Tribus, could you help my manager find me a good project? I might have retired from Xerox. He was 3 levels above my manager. Just imagine, he would have walked into my manager's office and said, find a man a good project. That would have happened yesterday. Now, about 5 years ago, I was writing my memoirs. And as I was writing that episode, it suddenly occurred to me that I had actually learned from it. Because thereafter, when faced with discrimination in medical school, later in academia, and certainly in industry, I reframed. And I think that is what was responsible for my becoming, as you mentioned, the first Black to be on the board of management of a top 5. Actually, at the time, it was a top 3 global pharmaceutical company.
Wow. Okay. So we know that you're MD, you have a PhD.
Yes.
And can you just sort of give us just a little bit about reframe to help us understand your past practice and now your current practice and how you're using your PhD and MD to just kind of give us, a piece of where we're getting ready to go?
Okay. Well, my PhD is in physical chemistry, and I practiced that for a short while. I told you the story of Xerox, and I went to medical school. I'm trained as an internist and in what's called neuroendocrinology. And I was at the University of Chicago School, Bristol School of Medicine. I was head of hypertension there in the Department of Internal Medicine when I was discovered by the pharmaceutical company. And so I joined the pharmaceutical company in 1984. And rose very rapidly. After 3 years, I rose from director to becoming senior vice president and head of research for the US, and finally became 2 years thereafter. I was there about 7 years, and then about 2 years after I was senior vice president of research, I became global head of research and development and executive vice president, board management, etc., of another company. What happened when I arrived at Ciba-Geigy, having trained as a physical chemist and having also done clinical research when I was at the University of Chicago, I was also at the NIH for a number of years before going to the University of Chicago. That's where I did my fellowship in neuroendocrinology and did research in that area. That made me an individual who understood the preclinical, the basic science side of the pharmaceutical research part, who also understood the clinical development side. And I think the training in both areas was probably what was responsible for my rapid movement within the industry.
Listeners, I've got to tell you one thing. He has a course. I was listening to part of it, and that's where I'm going to lead it to. Allegra.
Yes.
Can you talk to us a little bit about this research and how you did the education in regards to that?
Allegra is a very interesting story, and I tell you why. The story is the following. I was at what is now Novartis, it was Ciba at the time, as head of research for the US, and should have become the global head of research and development for Ciba, which shortly thereafter became Novartis. But because I was Black, they actually called me to Switzerland and told me because I was Black, and I would have been, one, the first American, and secondly, of course, the first Black to be on their board in Switzerland, that was not going to work. So I was not going to get that position. Wow. So I looked around for an American company and ended up at Marion Meridau, which was a mid-sized company, as global head of research and development. And when I was there, they had a predecessor drug to what's fexofenadine, which is Allegra, which had some problems. And as I was reading, regulatory was also under me when I was hired. And I was reading some of the reports from the FDA, and I became alarmed that, as a matter of fact, the company was trying to take this drug over the counter, whilst the FDA was saying, look, you've had some deaths here. We don't think you can take this over the counter. So I discussed this with the CEO, who basically said to me, look, you've just gotten here. You don't know all the background, etc. So I said to him, look, I've looked at this drug and I'm convinced that it's a metabolite that is active. And I have talked with the scientists, the chemists who've made it. They made the metabolites. They've tested some of these metabolites. I've selected a metabolite that I think does not have the problems that this parent drug has. And
Mhm.
if we can demonstrate that, I can develop this within 3 years. I can get it on the market within 3 years. Normally it's 6 to 7 years.
Right. Yeah.
And, he kept saying, no, no. And then finally, one day, Dr. David Kessler, who was the head of the FDA at the time, went on Good Morning America and announced that they were thinking of withdrawing the parent drug from the market. Whoa.
Wow.
So the CEO called me in and he said, please do what you were planning to do. And I was able to take fexofenadine, which is now Allegra, and as I committed to him, do a number of things, present to the FDA a development plan, and we were able to get it on the market within 3.5 years, I think it was. And
Wow.
yeah, that was the thing that actually made my my reputation a real sense in the industry. But it also, not only in that class of drugs like Certex and the like, it also pointed out that there are times when a metabolite is the active ingredient. And it is sometimes better to develop the metabolite, even though it may take a little bit more work than
Mhm.
just to develop the parent. But we were able to show that this metabolite did not have some of the side effects that the parent had.
Okay. So that's the reason why I had to let you know that I caught on to that part when I was in your course. And I was like, oh, gotta let people know he has some research and education to give to us because that is powerful.
Yes,
What you
no,
just
that is
did,
very
what you talked about, it is very powerful. So I just want to go into actual topic of discussion that I really, really want to hit some key pointers in regards to health disparities among healthcare workers. I think that is a very important topic. I think that's one of the reasons I have my tags. I had to remove some of them, okay, but I didn't want it to look too bad. But I wanted to make sure that we focus on how he's talking about the reframing methodology to overcome systematic discrimination until you walk in my shoes. And even from childhood, when he had to deal with some lies that actually were placed upon him, to where he is today, which he even had to deal with some issues in Germany, which we will
yes,
touch on, which was very enlightening to hear as you are fluent, at least
yes, I
for
am
what.
fluent in German.
Yes. Okay. A hot dog. I got it.
Sprechen Sie Deutsch?
I need to
Nein.
put you with my mother-in-law speaks German too. So
Ja?
my stepmother-in-law, she does speak German fluently.
Yeah.
Fluently.
Uh-huh.
I think it's really important that we kind of discuss about some of the health disparities among healthcare workers.
Mhm.
That's what we're here for. We're talking about health literacy. We're talking to people who are out there who are in the healthcare field. They can range from gender disparities, it can range from racial and ethnic, socioeconomic disparities, and how they impact the care of our patients, the consequences which happen to our healthcare worker and their well being. I think we have a lot to just discuss here.
Yes,
It's time to
yes.
unpack the health disparities in healthcare and how it relates to your book, because your book, you take us on a journey. And I believe we need to talk about some vocabulary so that people can understand some of the things that you and I are going to be discussing. Do you mind sharing some vocabulary with us? I think it would be probably pivotal. Maybe express some dimensions in which we look at the efficacy of equity. You talk about
Mhm.
privilege and preferences,
Mhm.
processes, and
Mhm.
prospects. Can you
Mhm.
define that for us just a touch?
Yeah, let me say the following, just to give a context,
That's
gives the
fine.
context of
Please
the book.
do.
My view is that every organization, starting with the family, is based on equity and inclusion. The leaders, the parents, set the tone, set the rules, the regulations by which things get done. And the children, the young adults, they set the behaviors by which each other are valued, are respected, and know that they belong to that unit so that they can produce for that unit. Whether it's the case of the family or an organization, they can be productive and profitable. So it's equity and inclusion. Now, when I wrote the book, I said, okay, how can we find some simple ways to look at equity inclusion? Well, in a company, for example, there are three things that people will immediately recognize when you ask them if they think they're being treated fairly. And they are there individuals there who are privileged? Doesn't matter what they do, they're not criticized, they get the best projects, etc. So privilege is one of the things that's recognized as to be able to judge whether there's fairness or not. What are your prospects? Namely, the work that you are doing, is your opportunity to grow in that company, your promotion related to the quality of the work you're doing? What are your prospects? What are the signals you're getting? And the processes, human resources, etc. Are they transparent? Are they indeed managed in a fair process? You look at those three things, those can give you a sense as to whether there is equity, high equity, or low equity in an organization. On the inclusion side, it actually turns out it is sometimes difficult to describe whether I'm included or not. But you know what? When I'm excluded, I feel it and I know it. Mm. And microaggressions are a simple way to look at inclusion or the lack of inclusion. And microaggressions are basically acts that are not physical, but are verbal and mental. For example, micro insults. Okay. That someone says something to you that is actually insulting, but it may not be to you. They may do it with respect to your tribe, if I may say, your family, the group that you come from. They make a comment about that group, meaning to make that comment about you, but they do it offhand to the group. So micro insult. A micro assault is somewhat similar. No physical contact, but we talk about verbal assaults, that they basically attack you verbally. And micro invalidations, they treat you as though you do not have the training you have. You're passed over, as though you are not at the level that you actually are. So you become invalidated. You look at those three things, you can again do a metric, if you like, about how important and how much is inclusion practiced in an organization.
So the way that, from what I was reading, your book holds a lot of information, a lot.
Yeah,
and I see the reason why you have 3 courses
yes,
that are available to meet the needs of those who are reading your book. Because I found that with me having read your book and then began the course dealing with healthcare disparities, it gave me even more insight of the direction and where you want our healthcare workers to go, how we can mitigate healthcare disparities. Mm-hmm. Can we just talk about the importance of a diverse healthcare workforce?
Mm-hmm. Here's some facts of life. Today, probably about 45% of physicians are women. 2.8% are Black women. Okay. We know that Black patients prefer to be treated by Black physicians because they recognize that they understand them, they understand their culture, they understand the reluctance they have to engage with the healthcare facilities. They think about the Tuskegee incident. I used to be amazed when I was a resident at the Johns Hopkins that many of the Black patients would not come into the hospital unless I agreed that I would be their doctor. And I discovered that their fear was they would be experimented upon if they came into the hospital. And years later, the Tuskegee experiment ran, I think, from 32 to 72. So here we are, 50 plus years later, that fear is still very great. There are also the cultural issues and the lack of the understanding of cultural issues. And this is not only true for Black patients. This is true for any group. The relationship between the recognition that that caregiver, that physician, that nurse understands your cultural group, you as a person, enables you to really engage better and get better care, seek care and get better care. So when we have such a paucity of physicians, and I'm going to look at the Black underrepresented group, when we have such a paucity, you recognize that it's no surprise that, for example, maternal mortality is about 2 to 3 times higher in Black women than it is in white women. There's no surprise. You look at all of the statistics, and it's no surprise that it is worse because we have this very poor workforce with respect to delivering care in the Black community.
You're international.
Yes.
And your intent is to make sure that people can understand that they can reframe the position and where they are, whether they're healthcare or not. But you do focus on doctors, and you did use one case scenario for a nurse.
Mm-hmm.
I think what I'm going to do is I want to talk about the Germany position, which I think will be an excellent segue to Dr. JD.
Mm-hmm.
Can you kind of give us a snippet of Germany? I think that will be an excellent explanation of helping us understand the positioning of Dr. JD and how that case study is relevant.
Yeah, okay. Not sure which aspect of Germany you're interested in.
When you're trying to speak up for yourself and acknowledge the professionalism that you have, that you
Okay,
expressed just a few seconds ago,
okay.
that you can have ABC elemental P behind your name.
Yes. Here's the situation with Germany. And I'm glad you talked about Allegra because that's key to what happened in Germany.
Mhm.
Because of Allegra, and I mentioned that the FDA had announced that they might very well withdraw the parent of Allegra from the market. That really depressed the stock. The company ran into trouble and, in fact, became an acquisition candidate and was acquired by Herx, a very large German company. And at the time it acquired it, and it made it very clear, the CEO said the reason he paid that amount of money for Marin Meridau was because of Dick Markham, who became the CEO at the time he was COO of Marin Meridau, Frank Douglas, and Allegra, because Allegra was on its way to approval. And they were just amazed at how we had done that. They combined their pharmaceutical company, which at that time was in the top 10 in the world, with the number one company in Germany. At that time, they owned 57% of it. They bought it outright. And Marin Meridau. And they formed Herx Marin and Roussel, which became a top 3 global pharmaceutical company. And they turned to Frank Douglas, who came from the smallest of these 3 entities to be the global head. Mm-hmm. Now, Frank Douglas arrives in Frankfurt, which was his global research headquarters. My global development headquarters was in the US. I arrived there and I'm having my first meeting with the German scientists. And I get up and I introduce myself. I speak for about 5 minutes when about 20 individuals got upset something I didn't understand and walked out. When I learned what they had said, I spontaneously said, I was just told that your colleagues said that they're sick and tired of individuals who can't even speak their language coming to tell them how to do science. Now, here's the deal. I know you think that Americans are lazy and won't learn a language. I will start trying to learn German. You will see me doing this because I will do it publicly. I might not succeed, but here's the deal. You have not been successful in putting drugs on the market in the last few years. I have been. So I will expect you to do your science differently. Battles ensued for 2 years. And finally, they came around. And I will tell you the end to this story. About 9 months into this, I was giving a talk to the whole site about the changes that I was going to make in the new global organization. I did it in German. I was speaking German. I could read German very well by that time. And I had, of course, an earpiece. I had a Dolmetscher, a translator. And at the end of it, I walked towards the front of the stage to do the question answering when the earpiece fell out. And spontaneously, I decided to go without it. I picked it up, put it on the director, and just went. Now, one Friday afternoon, I used to have these Friday sessions with my team, and there were only the Germans, members of the team around me would do it in German. One of the German members said, do you know when things turned around for you? And I said, no. And they said, you remember about 9 months into it when you gave the talk and the earpiece fell out and you just went without a translator, question and answering? Many of the Germans left that and said, this man is very busy. He had to learn the projects in the French company, the projects in the German company. Of course, he knew the American projects. When did he have time to learn German? If he took the time to show us the respect and to respect our culture, that he can now stand and fluently converse with us in German, then we need to not see him as an ugly American coming to tell us how to do things the American way, but to listen to what he has to say and give him a chance. They said that was when it turned around. And I said to them, this is an important lesson, because what I did not know that I had done then is that what I actually had done is that I had demonstrated that I too would be prepared to do something that was difficult, that they thought was difficult. Even though I might not succeed, I was prepared to do that and to show them that respect and to try to walk in their shoes so that they would show me the respect with respect to how we should change the way we do science.
Oh, we're running out of time, but I'm going to tell you, I could listen to you all day because this was amazing. When we improve our literacy, it does not necessarily mean by reading. It could be health, it could be mathematics, it could be reading, it could be anything. Collectively, we find ourselves to be more empowered.
Mhm.
And we can be more proactive and take the steps that we need to do to be a better well-being individual, a person who's more collective in him or herself, to meet the needs of their community, to meet the needs of their desire to advance. And I need to just touch base that in your book you talk about case studies, and there was something powerful, probably because I'm familiar with the ED. There was something powerful about the case dealing with Dr. JD.
Mm.
It speaks to volumes
Mm.
to
Mhm.
how we care
Mhm.
and how sometimes as advocates for our family
Mhm.
that we see more needs to be done,
Mhm.
and it sometimes is often dismissed. And I think even though you're going to give just a glimpse of what happened with Dr. JD, there is something powerful about how even we as caregivers
Mhm.
or we as healthcare workers can reframe how we meet the need of our patient.
Mhm.
Go for it. I'm really listening all to you.
No, the Dr. JD case was a very interesting case. This is a Black female who was the head of the ED, the emergency department of a major inner city hospital. And in came a patient, a minority patient, actually, it was a Hispanic patient, complaining of chest pain. She evaluated the patient, called the resident who was on call and medicine to come down, evaluate the patient. This was a white young man. He came down and she doesn't know what happened, but the next thing she knew, the patient was being discharged. She approached the patient to find out why the patient was dressing to leave. When this resident approached her, pushed her aside so that she would not interact with what was really her patient. She, of course, talked to him about it. He was quite rude, and she complained about it. I wouldn't go into the rest of it, but of course, she was quite concerned about here. She is the head. It's her responsibility to make a determination about which patients should be admitted to hospital or not. She had made that determination, and someone much junior to her, a white young man, not only ignores her recommendation, but discharges the patient. And of course, her concern was how does she get redress? Now, important as that is, in the reframing, as we discussed with her, there was something that was being missed, namely the patient. And if we had focused on the patient, here is an underrepresented person, a patient who is being sent out, who might very well die, who could have a heart attack. But if she focused on the patient and took that forward as the issue to be discussed, as to how decisions are made, how are her decisions upheld when she makes them? How does the ED department and the medicine department work together to ensure that their residents, okay, follow the protocols, etc., and those are clear, we will do much better for patients. And guess what? Her issue would also be addressed, namely in respecting her as a Black woman and as head of the ED, the emergency department. And that is the part about reframing. What we say, finding a better problem to solve. And that better problem to solve was that issue of healthcare disparities what was happening to that patient and focusing on that problem, it actually solved the racial problem, the racial discrimination for that individual.
Thank you so much for explaining it. I just want to say thank you so much, Dr. Douglas. We've addressed a lot of issues, a lot of concerns. Hopefully, it will help some people think about the impasse of feeling that you have imposter syndrome when you have your doctorate or PhD or MD, your PA or NP, and being a minority can sometimes be subdued in whom you are, but it's not really imposter syndrome. It could be a way that you're fighting your own personal oppression and having to learn how to reframe how you work. So I thank you. I thank you very much. I think hitting the topic of health disparities and understanding it from this point of view and understanding that this is health literacy
Yes.
on our part, I think that does a world of good. I want people to know how to get in touch with you. Talk to me.
Well, they can go to my website, safehavendialogues-llc.com. Safehavendialogues-llc.com. The book which you've been showing, Until You Walk in My Shoes, that is available on Amazon and on Barnes and Noble.
And he also has courses.
You also have the
Don't leave
online
that out.
courses, one of which you clearly took. It's interesting because on a phone call this morning, I did a course last night, and it was an overview of the reframing process. And one of the attendees actually called me this morning and said, I wished you had, and he had read the book. He said, I wish you had selected Dr. JD example because there were so many individuals on the Zoom call who were MDs and nurses. And I wish you had chosen that one as an example.
I tell you, that one's just powerful. It's powerful. And you also have another one in there too.
Well, I thought that, for me, the Dr. MS, because this is a physician,
Yes.
who is being ill-treated. And one of the things that
I was gonna say
amazed
that's the other one I had tagged. I don't
uh,
know if they can see it, but I had it tagged.
yes, I can see it. Yeah, Dr. MS. And the thing about that is that I learned something. We talk about fright and flight syndrome.
Yes.
And here is a physician who is being discriminated against, going through off, and who is not defending herself, who's not reaching out. And it's suddenly I began to realize that sometimes people freeze. And so it's not only fight or flight, sometimes they freeze in the situation and cannot defend themselves. And so they suffer tremendously. I will tell you, that's the case that gets me every time.
It got me too. So I had to pick which one I wanted to talk about. I'm gonna be honest with you, that one hit me hard too.
Well, because when I
That one hit me
interviewed
hard.
her, I kept saying, but Doctor, MS, I don't understand. Why didn't you reach out to your colleagues for help? It's a very powerful case. And so we underestimate the impact. Just the last year, and I know you know this, Boston University published this study where they had followed 48,000 Black women for over 20 years. And those Black women who reported racism at work, in dealing with the police, or in housing, had a 26% greater incidence of coronary artery disease and 38% incidence of strokes, also occurring at an earlier age than those who did not have racial experiences. So the impact of systemic racism, systemic discrimination, be it based on gender, sexual orientation, whatever, the impact on well-being is really underestimated.
Mm-hmm. Well, I want to say thank you so much, Dr. Douglas. We are appreciative to have you in our presence on Cold Press Conversations. And if you want to learn more, he gave you all his information. And I thank you so much for tuning in. I hope you enjoyed this episode of Cold Press Conversations. If you love this episode as much as I did, I need you to head on over and subscribe so you never miss an episode. This is Dr. Jewel signing off to health and cognitive happiness.